welcome everybody to our webinar today of the role of forensic nurses in emergency response and infectious disease. Our speaker today is Kaylin Knight. Kaylin is currently serving as a forensic nursing specialist within the Education and Publications Department at the International Association of Forensic Nurses. Additionally, he is a practicing sexual assault nurse examiner at Nebraska Medicine in Omaha, as well as a medical legal death investigator in Pottawatomie County, Iowa. Kaylin is also an adjunct lecturer for the Master in Forensic Nursing program at Oakland University for the Quality Legal Matters of Death course and clinical. Kaylin earned his Master of Science in Nursing Leadership and Master of Business Administration from Nebraska Wesleyan University, and his Bachelor of Science in Nursing from Clarkson College. Kaylin has extensive experience in clinical practice and education development from his prior professional nursing experiences, including emergency, trauma, infectious disease, biocontainment and quarantine, nursing education, and forensic nursing. Kaylin is committed to bringing innovative ideas to forensic nursing and fostering expansion and support for the specialty as a whole. And with that, I will turn it over to Kaylin to take us through today.
Thank you so much. I will share my screen here. I appreciate everybody hopping on to this presentation today. It's always an interesting topic for people because I come to find that there's a lot of people who don't know a lot about forensic nursing or really what forensic nursing is. So that is what I hope to provide you all today, and then give some examples specifically from an infectious disease and emergency disaster response standpoint. So I'm going to skip my bio slide because he just went over that. So to really start this presentation, I think the most important thing is just building that foundation from the bottom up. So what really is forensic science? And it's the Latin for forensis comes from the public to the forum of or public discussion. So argumentative, rhetorical, belonging to debate or discussion is the older definition when it comes to forensic, but more in modern day, it's anything relating to or used in court proceedings or suitable for court law. The forensic sciences have historically, and the general public's idea regarding forensics has always revolved around civil disputes, criminal proceedings, laws, regulations, which is a lot of what it is, but it also contributes to the protection of public health, which is really where forensic nursing stems from and the target of the conversation today. So many of you probably have historically had that mindset that forensics relates to criminal law. Everyone thinks of CSI technicians and fingerprinting and DNA analysis, which is a part of forensic, but we have to remember that a lot of the reason that what we do and the purposes we perform our skills as forensic nurses is coming back to that community and public health standpoint. And there are so many different disciplines of forensic science, anthropology, criminalistics. I'm not going to read all of them on this slide, but the one that is often forgotten is the forensic nursing science. And with forensic nursing science, what is forensic nursing is a common question that I still have to answer nearly every single day from people as I give presentations. But what forensic nursing is it is the practice of nursing globally when the health and the legal systems intersect. So as forensic nurses, we really live in that middle space to make sure that the patients are receiving holistic care while also making sure it's not at the detriment of legal outcomes. We try to remain up to date on everything relative to patient rights when they've experienced violence, while also making sure all of their medical needs are met, and we're making sure that any of those legal needs are embedded into that medical care going forward for that patient's plan of care. We primarily focus anywhere that violence happens. So when it comes to domestic violence, sexual assault, physical assault, elder abuse, human trafficking, workplace violence, all of those areas are regions that forensic nurses are currently practicing in. If victimization happened, the forensic nurse should be included. And then one of the other benefits of forensic nurses, which I'm sure many people on this call can attest to, is healthcare providers do not like receiving a subpoena. When you have been involved in a patient's care or involved in any type of situation as a healthcare professional, and you receive a subpoena as part of that, a lot of people start to sweat and they get anxious and they don't want to get subpoenaed. Well, in the field of forensic nursing, we want to receive that subpoena because it means the care that we provided a patient, meeting both their medical and their legal outcomes, is proceeding forward in the way we want it to from a justice standpoint. Because we know that there's a lot of short and long-term health consequences when patients experience violence. And the long-term health consequences of violence are really an afterthought for a lot of people, when not reaching that justice can contribute to so many additional problems for that patient in the long run, both physically, emotionally, mentally, in the form of relationships. There's so many other things that people don't consider when it comes to gender-based violence and violence, period. So that's really why forensic nursing was developed. To look at the history of forensic nursing, we really are in our infancy, if I'm going to be completely honest. So the first forensic nursing programs really started developing in the 1970s. And back then, it was primarily focused only on victims of sexual assault. So nurses wanted to provide specialized care to sexual assault victims presenting in acute care settings or community health settings. And then in the 1980s, who is referred to as the mother of forensic nursing, Virginia Lynch, who's photographed on this slide, she was working in the OR at the time in a trauma center and recognized the inadequate focus on the actual violence for the patients that they were treating. So the victims of violence, the death that was happening, the legal issues surrounding what happened to the patient she was encountering, there was nothing in the healthcare setting relative to making sure evidence is maintained, making sure that the documentation is what it needs to be, and that the appropriate reports are being made. And the reports being made is still an ongoing process, even now in 2025. There will be times where there's patients presenting in the emergency department where what they are being treated for is a mandatory report. And people don't recognize that because we are so focused in healthcare on meeting the medical needs. And that's really, again, why forensic nursing exists. It's to the people who are focused on medical needs, the emergency medicine or primary care providers, like you focus on the medical standpoint, but bring us in to help build that bridge from the forensic nursing standpoint to the legal outcome standpoint. And it wasn't even until 1985, a lot of people don't realize this, that violence was designated as a healthcare issue by the US Surgeon General. And it was around that time that Virginia Lynch again recognized inadequate education for healthcare professionals, specifically nursing, relative to violence. So at that time, she actually started working for a medical examiner's office out of Texas from the violence and death standpoint, and wanted to create an advanced educational offering for nurses relative to forensics and violence. So she actually created a curriculum, proposed it to a university. Their board of regents accepted it, and it was the first official master's in forensic nursing program to be developed. And then after that program was developed in 1991, the American Academy of Forensic Sciences actually recognized forensic nursing science as its own discipline. And that association actually expanded their membership to include nurses practicing in the field of violence and forensic nursing. 1992 is when all of the nurses practicing in forensic nursing, a group of them came together and actually developed who I now work for, the International Association of Forensic Nurses, where we are focused on the ground, like the boots on the ground education for forensic nurses, seeing and treating patients in acute care facilities, community health facilities, or even in military settings. And then in 1995, it was then the American Nurses Association recognized forensic nursing as a specialty. So it really goes to show that we really are in our infancy as a specialty, but we are making a lot of ground, and there's a lot of hospitals and organizations internationally that are now viewing forensic nursing as a standard of care for anyone who has experienced violence. Some regions are ahead of others, but there's definitely a lot of room for growth. Currently, only 25% of hospitals in the United States actually have forensic programs in-house. That number is a little bit larger when you start looking at the telehealth services that forensic nurses are beginning to offer more rural and community hospitals. But we are slowly growing bigger and bigger. And then with grant funding and other private funding, programs are really drastically growing to expand services for different types of violence within a variety of different communities. I'm going to be going over all the different types of forensic nursing in general here shortly, but what does forensic nurse training actually look like? It varies depending on the type of forensic nurse someone is. So forensic nursing is the specialty, while the subspecialties of forensic nursing are your sexual assault nurse examiners, forensic nurse examiners, your forensic nurse death investigators, legal nurse consultants, and then correctional nurses, forensic psychiatric nurses, and disaster nurses. And as you can, like, you look at that list on this slide of those subspecialties, it's all different areas of practice that, again, there are legal considerations and violence occurred, and you have a healthcare provider there that's going to help make sure that that bridge occurs. Now, to become those types of forensic nurses, the training varies drastically. Typically, for most of them, it's some type of didactic course, whether that be like a 40-hour online or in-person course, followed by a lab for the actual psychomotor hands-on skills practice. Some people actually pursue that formal coursework, like the program I mentioned that Virginia Lynch led, where people will take a master's in forensic nursing program that provides a lot of the coursework that all of these different types of specialties require. If not all of this coursework, a majority of it, so that upon graduating, people only have to attend a clinical skills lab and they have a lot of options depending on what avenue they want to go down. And what you will find as well is a lot of forensic nurses practice in multiple subspecialties of forensic nursing. So, for example, I'm a sexual assault nurse examiner, forensic nurse examiner, which you'll see the difference between they're essentially the same thing. I'm a forensic nurse death investigator, and I have background with legal nurse consulting, where people will ask us to come on as expert witnesses to speak to something such as non-fatal strangulation in an intimate partner violence situation. So a lot of us practice in a few different realms. After getting that didactic or coursework completed, then it's preceptorship with an experienced forensic nurse or on-the-job training. So just seeing patients, learning the laws and the regulations relative to the work that we're doing in that region, that process can take about a year to fully get trained and be able to see these patients confidently and competently on your own, and make sure that you don't violate the rights, because there are serious implications if we do not know a patient's rights in a region and we're providing that consultation, we're consenting them for a medical forensic exam, but we describe something incorrectly and the patient finds out that they weren't given the correct rights. That not only puts you as a professional at risk, but it puts that entire organization at risk. So again, that's one of the other reasons forensic nursing really exists, because we are the subject matter experts on those areas, and we work very closely with other organizational team members, such as the compliance team, regulatory department, risk management department, to make sure that we're supporting the patient's needs, but also not putting any liability up for the organization. And a lot of these subspecialties do have their own specific certification. So like I'm a SANE A, which is a sexual assault nurse examiner, certified for adult and adolescent populations. I'm also a certified death investigator, being a diplomat of the American Board of Medical Legal Death Investigators. So all of these have their own types of certifications available. So next, I kind of want to go over what all of these different types of forensic nurses are. So as sexual assault nurse examiners, um, a, a forensic nurse examiner is essentially practicing as a sexual assault nurse examiner without having that certification. So they have not sit for a proctored board certified exam yet. So they refer to themselves as forensic nurse examiners. And then once they pass that board certification, they then can escalate to that title of sexual assault nurse examiner for the adult adolescent, pediatric, or all populations. But typically, what sexual assault nurse examiners and forensic nurse examiners do is they respond to any cases of sexual violence or assault. They will see domestic violence and intimate partner violence patients, child abuse and neglect, elder mistreatment, human trafficking, and workplace violence. So, for example, the program at Nebraska Medicine, where I currently practice as a SANE A, we provide consultation for all of these except child abuse and neglect, in which we partner very closely with our local child advocacy center, where if we are contacted regarding a case that does qualify as child abuse or neglect, we will do our initial intake and documentation about the circumstances that we're aware of, but then we do a warm handoff to who we work with, Project Harmony, who will then do the ongoing support and follow-up for that situation. So that's a little bit about sexual assault nurse examiners and forensic nurse examiners. Later on in this presentation, because the focus is on SANE, I'm going to go over the actual skills and the tasks that we perform. So I won't go over that right now. Another type of forensic nurse is forensic nurse death investigators. And typically, as FNDIs, what we do is we work for a local coroner, medical examiner, or a mixed system in our region. And we are essentially on call to respond to any deaths that occur outside of a healthcare setting that are suspicious, unexpected, or unattended deaths, meaning there wasn't someone there at the moment they died to pronounce that death. And we conduct the on-scene investigation, including doing a scene walkthrough, interviewing everybody who's present, so next of kin, witnesses, talking with law enforcement about what they've learned. We process the scene and the body, taking photographs. We work collaboratively with crime scene investigators because crime scene and law enforcement have jurisdiction over the scene, while a death investigator has the jurisdiction over the body. So we process the scene together, we process the body together, and then we work with our coroner or medical examiner to determine if an autopsy is indicated in that case. And if it is, then we help coordinate all of that, whether that office specifically does their own autopsies or they contract with a private agency that conducts autopsies for them. And then once all is said and done, we help certify the cause and manner of death with the coroner and medical examiner. And all of that we do not only has legal implications for the family and the next of kin and life insurance, but also there may be criminal hearings or civil hearings. But most importantly, public health, because we have to make sure deaths are certified correctly, because all of those statistics used in research everywhere regarding morbidity, mortality, what's going on with like injuries with commercial equipment, all of those types of things come from thorough death certificates that are reported through the vital events system in the United States. So that's kind of the purpose behind the death investigation system. Another part of forensic nursing is legal nurse consulting. So they do a variety of different things. Some legal nurse consultants never testify and they just help with records review and educating lawyers. Some write up formal reports, review medical records, testify. So it kind of depends at what level that legal nurse consultant wants to practice at. But a lot of what it is reviewing medical records, educating attorneys on what the standard of practice is, as well as if there's anything in those records that should pique their interest, conducting case reviews to see if anything should have been done differently. Again, if the standard of care was met, creating chronologies and reports regarding a patient's plan of care that an attorney can use when building their case. Provide professional consultations or, like I said, testimony, such as an expert witness speaking to those standards of care and being able to answer those questions and give the current state of research on a certain topic. And they practice in a variety of different settings. So some people contract with law firms, insurance agencies, risk management departments. There's actual government agencies. One of my team members at the IAFN is a government contractor regarding sexual violence legal nurse consultation cases that happen. So there's a variety of different areas that those forensic nurses practice in. And then litigation support firms as well. So there's some people out there who have their own LLC and just take on consultants where they put out their information and attorneys will use them at their rates and pay them to help be a consultant. So again, it's where that legal and that healthcare system kind of intersect is where those forensic nurses are helping out. Correctional nurses, again, you're in a setting, a prison or a jail for incarcerated individuals. So that is another area of forensic nursing, and there's a lot of psychiatric treatment and a lot of preventative care and ongoing needs and violence that happen in prisons and jails and detention centers. So correctional nurses are also forensic nurses. They help with primary health care. They do help manage chronic conditions with the care team at that facility. They do respond to emergencies in those settings. So that's another really key importance when it comes to anywhere that violence takes place. That correctional nurse is going to respond, and they're responsible in that setting for making sure all the appropriate reporting and legal implications for that violence are taking place in the correct way, as to not put the patient at risk or their legal outcomes at risk. And then also just education and prevention. There are a lot of educational programs led by correctional nurses. For example, the prison rape prevention bill, while a lot of correctional nurses are not necessarily sexual assault nurse examiners or trained to perform those exams, they are subject matter experts on those laws to make sure that those patients who do experience prison sexual assault do get the care that they deserve and that they need after it happens in a controlled setting like a correctional facility. And then forensic psychiatric nurses. This is something that is really starting to peak quite a bit, especially like there's a few regions in Canada that are increasing the utilization of forensic psychiatric nurses. So on the photo on the bottom right, you can see there's a nurse in that vest. It's actually, they refer to themselves as a police nurse, and what they do is they are part of a specific group of law enforcement who respond to situations of behavioral crises, IPV, and domestic violence to help de-escalate the situation, prevent further injury, and also decrease emergency department admissions and focus on de-escalation at the scene and connection to the resources that those individuals actually need, whether that be mental health intervention from a facility who specializes in that, shelters, IPV follow up with advocates. All of those different things is another area of forensic nursing practice to help minimize the burden on organizations and ERs and help meet people where they're at and get rid of that middleman, such as an ER visit where now they're sitting in an ER in psychiatric scrubs for an extended period of time waiting for a bed to be open. Those agencies have really begun to help the intervention happen immediately with someone trained to provide that intervention and get them to the resources that they actually need. And then the last one I'm going to talk about is disaster nurses, disaster nursing. So this is another area of forensic nursing because many disasters, whether that some are human made, some are not, but regardless, crime happens when disasters happen. We see violence increase. We see circumstances where if it's a time of war, that is violence. Things are happening. Forensic nurses offer something there. So I actually have a lot of colleagues who work for the American Red Cross to respond in those regions when violence happens. The Medical Reserve Corps, the National Disaster Medical System is an area of forensic nursing because a lot of the time they may respond to areas of violence. And it was something I didn't include on this slide is actually also the DMORT. So the disaster mortuary response team also may have nurses on that team who are helping with identification of deceased individuals, assessing bodies to help determine that cause of death. Was it as a result of whatever disaster is happening in that area, or was it violence, or someone trying to cover it up? Those are all, again, areas that forensic nurses practice. And they do help before, during, and after. So whether that be prevention, education, follow-up, helping determine what the allocation of resources is. There's actually a lot of people who are practicing in the field of forensic nursing who don't even really recognize how they are practicing as forensic nurses. So that's something that, again, at the International Association of Forensic Nurses is something that we really try to focus on and expand people's understanding of what forensic nursing really is. When it comes to disaster nursing, these are different regions that people may follow up, may uh, practice in. So when it comes to general disasters, mass casualty incidents, natural disasters such as hurricanes, tornadoes, earthquakes, all of those regions are areas that we will respond as forensic nurses, part of whatever type of response humanitarian group or response system at that region level we are part of to provide our forensic nursing services. And there's often times where people are practicing in a variety of ways. So there's a lot of forensic nurses that are trained as ER nurses, for example, who are part of the National Disaster Medical System, who are responding, providing that care from within the MDMS from a medical standpoint, but also have that forensic nursing background to help bridge those needs for that patient. And they help develop those policies and speak to all the what ifs that may happen to ensure that we are thinking through all the possibilities before that disaster actually occurs, which is what we're going to talk about here shortly in a case example. Human caused again, a human caused disaster is violence. So there's opportunity for forensic nurses to be involved, not only meet those medical needs, identify if there's any intervention from a medical standpoint, but also make sure that there's appropriate documentation related to what that person's gone through that could be used in whatever method that patient ultimately decides it needs to be used at a later time. And then disease outbreaks, which is what the focus of the rest of this presentation is going to be about, is we're going to talk about how forensic nurses play a role in disease outbreaks, such as COVID-19 pandemic, Ebola virus disease, and monkeypox. The focus is going to be from the standpoint of sexual violence, because that is still the number one type of violence we see across the board is sexual violence and gender-based violence, whether that be in a disaster, just within a community, a man-made disaster, whatever it be, because oftentimes gender-based violence is an afterthought where we, as forensic nurses, really advocate that when you are putting policies in place and you're developing a specific system, you need to think about all of the possibilities that could happen so that you're not so tunnel visioned on, say, a person who has an infectious disease. Maybe they have something else that happened to them in the background that we also need to acknowledge at the same time that we are focusing whatever medical treatment they need. So we'll bridge that a little bit here shortly with the case example. So next we'll talk about building that bridge between sexual violence, emergency response, and infectious disease. So a term I just want to share quick is that term syndemic, which I'm sure many of the people on this call are familiar with. But syndemic is the interaction of two or more diseases or health conditions within a population that are typically exacerbated by social and environmental factors, leading to a greater burden of disease and health disparities. So again, when you have a case of an infectious disease, so we'll say COVID-19, gender-based violence. So we have people who are in an intimate partner violence situation in their homes that they are now confined because of lockdown orders. Plus, you have that level of community violence. You're going to see a transmission of COVID-19 go up. You're going to see an increase in health disparities because there's going to be less resources available. So these are all the things that you have to think about that were seriously not acknowledged, honestly, in the early stages of COVID-19. So a glimpse into how pathogens, policy, and gender-based violence intersect with consequences. Again, looking at that stay-at-home order and lockdowns, there's increased household stress at those times. So one of the things that we encountered was people who were stuck in households that had IPV. There was a serious increase in that gender-based violence that happened because of all of the other stresses that can happen from, okay, there's a decrease in finances because maybe someone's out of the job now, but also there was an increased lack of resources for people who are in those intimate partner violence situations because advocacy agencies were no longer open or accepting in-person consultations, where then you had to figure out a way for that telehealth services to be met for those patients. So that was one of the challenges that we were facing, is those stay-at-home orders put people in IPV situations at a significantly higher risk of intimate partner violence and potentially intimate partner violence homicides. Something that was noted in research, such as in other African countries, was because people were locked down and there was those stay-at-home orders, it decreased the opportunity for adolescent females to pursue education because they weren't going to school, getting that higher education, and that was found in the research to put them at increased risk of being at child marriage. So again, long-term consequences of these immediate policies that are being put into place without thinking it through. And don't take this as lockdowns and stay-at-home orders were not the right thing to do, because that's not how I feel. But what I do want you to think about is, when those decisions are made, are we at least putting some thought into what we can do to decrease the burden that's going to have on those people who are experiencing violence? And again, that's what those forensic nurses bring to the table when you have them part of that conversation early. We know this has to be done, but how can we do it in the best way to make sure we're still keeping people safe? So that kind of leads to the lack of foresight in public health policy. Something else that was found in some research relative to Ebola and COVID was during lockdown and confinement and public health education. One of the biggest things that was found in a qualitative research article was the gendered household labor division in certain countries, such as women having the bulk of the work to do in the household. Well, when they didn't have running water in their home, but they were educated to prevent the transition of infection by frequent hand washing, they had to make more runs to get water for their home. And in that quantitative or qualitative research study, what they found is, when women leave the home in some regions, their risk of being sexually assaulted and experiencing sexual violence significantly increases. And because of that, there was a huge spike in women being sexually assaulted because they were the ones responsible for the labor in the household, which involved going and getting the water for the home, going into the community where there's already violence happening that is now spiking because of the pandemic or disease outbreak that is occurring. So again, thinking through those types of things, and gender-based violence health services and the resources associated with them were deemed non-essential in the early stages of the pandemic, where people couldn't readily access advocacy agencies to talk about what their resources when they are being beat up at home and they want to leave, but now there's no shelters because the bed number decreased because of social distancing needs. There's nowhere for them to go. They have no social system or support, or maybe they want to go somewhere or stay with family, but that family has an illness now that they can't enter that home. There's so many caveats and sides to this that you have to think about regarding these policies. Another big thing that was found was sexual and reproductive health services not being readily accessible. So there's decreased psychosocial support for pregnant females who were experiencing those different emotions coming with pregnancy. There's decreased access to the reproductive health care, and there is also an elevated number of unintended pregnancies resulting in elevated unsafe abortions being performed because women didn't have access to that, specifically when it was a pregnancy that was the result of a sexual assault. So that puts them at higher risk for death themselves, but also significantly long-term health consequences and putting them at risk of higher health disparities. So thinking through all of those things, there are so many considerations when it comes to writing these public health policies and trying to meet their needs. And that's why forensic nurses kind of place ourselves as a collaborative specialty to include in policymaking, where we know what needs to be done from the whole public health standpoint when you're dealing with an infectious disease, but let us help think through what are the gender-based violence considerations and who can we work with and who can we talk with to develop better ways to support those individuals while also instituting these community and public health measures. From the statistical perspective, so this is just something that I think is worth sharing. So the United Nations and CARE conducted research regarding the ongoing conflict that's occurring in the Democratic Republic of the Congo. And they have found that a single week is having upwards of 500 cases of sexual violence, and 150 of those cases are involving children. And to put that into perspective, that's about the volume for a majority of forensic nursing programs in the United States in a single year. And because their volume is so high, they no longer have post-exposure prophylactic kits available. And what that post-exposure prophylactic kit is, we're talking treatment for STIs, post-exposure prophylactic for HIV, vaccinations such as HPV, hepatitis, tetanus, and pregnancy prophylaxis, all of those things. Not only do they have timeframes, but they're just not available. So because the number is so high and they're not able to get ahead of it because of all the conflicts are happening, there are so many patients out there going untreated, which is going to cause long-term health disparities for themselves and their family and their children. Nigeria also saw a 56% increase in violence reports in the first 2 weeks of the COVID-19 restrictions, which there's just now research really starting to come out regarding the United States as well, that violence did significantly increase in the United States as well, specifically when it came to intimate partner violence and domestic violence because of the financial strains and stress put on families because of lockdowns or different not being able to see families, not being able to access their support systems. So there was a lot of increases in the violence, but also a decrease in the number of forensic nurses that were available at that region during that time because a lot of the healthcare workers were pulled to work in other areas of the healthcare system. So as a forensic nurse during this time, I was a forensic nursing program supervisor who was pulled back into staffing from the emergency department standpoint, which further limited the resources that forensic nurses could offer to the patients who were presenting and experiencing sexual assault and domestic violence. We saw a huge drop in reports in the ER at that time, which was not because it wasn't happening, it was because people couldn't access us. So that was a really disappointing burden that was not intended, but happened during the pandemic. This is an article that I encourage you all to review. I just thought it was really interesting because it really puts into perspective how gender-based violence and infectious disease outbreaks really do have a huge impact, and they kind of feed into each other exacerbating the problem. And I liked this article because it's a little bit more recent, but focus on what was learned from Ebola, Zika, and COVID-19. So it's a very good article to review. But what I want to kind of talk about specifically from the article is they discuss the conceptual model for policymakers when it comes to addressing the syndemic of infectious disease and gender-based violence. And what this was what are the bidirectional risks pathways associated with both of them? So how are they feeding into each other? How can we as healthcare professionals act upon them, and who should be involved in that process? So I'm going to lead off with the first case example. This is going to be relative to COVID-19. This is a true case example, and it's really what I'm considering a micro level because we didn't really know what we were doing at the time when we did this, as far as the good outcome that was going to come with this program, but it puts into perspective why forensic nurses were involved in it. So, like I mentioned earlier, at Nebraska Medicine, we respond to adult adolescent victims and survivors of sexual assault, domestic violence, human trafficking, elder abuse, and workplace violence. During the COVID-19 pandemic, employees within our healthcare system that were experiencing domestic or intimate partner violence in their personal lives began to face additional challenges that started making them themselves bleeding into the workplace where their colleagues were beginning to become aware of what was happening, or they were in such a dire situation they started reporting to their supervisors, their managers, their educators, or just their friend colleagues what they're experiencing and wanting help. Um, One of the organizational policies at the beginning of the COVID-19 pandemic was employees of the healthcare system cannot enter the hospital without an ID badge present. Any employees presenting to an entrance of the hospital will be turned away at the door and must go home to get their badge if they don't have it. Now, the intended outcome of this was positive. It was non-employees were prohibited from entering the organization at the height of the pandemic, but an unintended outcome of this was perpetrators of IPV began stealing the badges of their significant others to prevent them from being able to go into work for the purposes of controlling them, isolating them, or trying to get them fired. So an unintended outcome that was not anticipated when this policy was put into place. So when we're looking at the bidirectional risk pathways between the infectious disease of COVID-19 and gender-based violence, COVID-19 increased the risk of gender-based violence because there was the lockdowns and confinement that we've discussed, the economic stress that was put on the households, there was disrupted support systems so they couldn't access whether that be therapy or advocacy agencies that they would follow up with. They also had that social isolation from not being able to see friends or family that would typically be there to support them because of the social distancing. And there was also reduced access to justice because the court systems really got held up during this time and things slowed quite a bit, even with things as simple as getting protection orders. Um, on the flip side, experiencing gender-based violence also increased their vulnerability to COVID-19 because people would not be able to seek health care out of fear of repercussions from their abusers if they were to find out. They couldn't access shelters even if they wanted to leave because shelters were either closed or the already not limited number of beds significantly decreased because of the social distancing requirements. Um, they had a weakened immune response because healthcare workers were working day and night, extended hours, in other conditions that they weren't used to, increasing the stresses, increasing the risks of getting sick, or just increasing the opportunity for contracting the illness. And there was also a lack of autonomy because it really gave abusers and perpetrators the ability to even more control the actions of the individual that they were abusing. So we began looking at how can we act on this as a healthcare organization. So we know that this policy needs to be in place for these reasons, but we also know that this is an unintended outcome of what's happening. What can we do to still support our colleagues while also addressing the mission and protecting the public health and the organization? So a lot of it came down to things that we already do. So just making sure we're screening for gender-based violence when people are checking in, even if they're coming in for COVID-19 symptoms, we cannot be skipping the domestic violence screening questions. Advocating for those private safe spaces to be able to talk, which during the COVID-19, because visitors weren't allowed, it was a lot easier to get people alone to ask them these questions. So that was a huge benefit that we did have. Collaborating with shelters and legal services, really talking with law enforcement agencies and talking with the local shelters and saying, what are your capabilities right now? How are things changing? What support can you give us that we can then pass on to the patients that we're seeing? So a lot of it was just conversations with different stakeholders. Utilizing telehealth creatively was another really big one that we would start to utilize to provide our services. And then educating, just educating, period. Everything that you're seeing on this slide really came down to how are we going to act on it? We need to do workplace safety planning. We need to help support employees while they're at work, providing us workplace safety planning because we know that some things may be a problem for one person, but not the next. So we need to focus on that individual's needs. And the thought behind that was, let's do workplace safety planning for the people who are experiencing this. and then who needed to be involved in it. So this was a huge cohort of people that were involved in developing what our response was going to be. And this ended up becoming a more formal program. So this is a list of everyone we talked to and included in the conversations about we want to meet the needs of our employees of our organization who are experiencing intimate partner violence, and the violence that they're experiencing is increasing because of the COVID-19 pandemic and the isolation. So what can we do to meet their needs while also meeting the guidelines regarding public health? Well, what ended up happening was we built to the SOAR program at the organization, which stood for Strength, Opportunity, Autonomy, and Resilience. And what it was is a program specifically to support employees who are experiencing domestic violence or intimate partner violence in their personal lives, and actually doing workplace safety planning with them in the workplace when they're expected to be at work and they're safe and away from their abuser. And then we also would help coordinate telehealth personal safety planning with advocates with local advocacy agencies. So we did workplace safety planning. They met with a community advocate to talk about personal safety planning. And then we tried to help be the liaison to whatever specific needs they needed, whether that be obtaining protection orders, making a report to law enforcement, getting a prior abuser off of their benefits, moving their work site location because they're being stalked. All of those things in the height of the pandemic is what the SOAR program did. People who are experiencing that violence, forensic nurses led that SOAR program to meet their needs and educate them and help them however we could. And one of the other solutions, back to where this case study started, is the solution to the initial badge concern. So all participants in our program, we educated them on what the process was if their badge was stolen by their abuser, which included immediately notifying public safety so that badge could be turned off so the abuser couldn't access the facility, but also the SOAR program coordinator serving as a liaison between the badge office, the employee, and their home unit where they work to make sure that they're not sent back home and their abuser stealing that badge doesn't work. And now they're safe. They can report to work. We help them get a new badge, and we also help them connect to more resources relative to what they're experiencing. And then all of this SOAR program kind of opened up to what are all the other what ifs that could happen? And that's kind of where we went from there. We thought through all the what ifs during the pandemic that if someone experiencing violence could happen. And as part of the SOAR program, we proposed ideas on how to address it. And we met with the organizational stakeholders to find out what was possible or what we could do within our purview. So that's more of a micro example. The next one I want to give is a larger example, which you're all probably going to kind of chuckle, but I'm giving you a perfect storm in this next case study, but I just want your brain thinking. This is not a true case. It's just thinking about how would you handle this. So say a 36-year-old female serving as a humanitarian healthcare worker in the DRC during the outbreak of Ebola virus disease is currently being transferred to the Nebraska Biocontainment Unit in the US because of a positive EVD serum test following exposure when assisting with the delivery of a baby. Following development of a fever and a headache, she tested positive on July 6, 2025, and is set to arrive at the biocontainment unit on the 9th of July at 10. She notified the medical transport personnel while en route to the biocontainment unit that she was sexually assaulted by a peer humanitarian worker on July 5th around 11 p.m. And she had not told anyone yet, but is now concerned that maybe he could have contracted EVD from her and he might be at risk of assaulting other women. And the reason I chose a case study like this is because there was research that violence happened between humanitarian workers during certain pandemics. So while it seems like a stretch, it is a possibility. And that's why I want people thinking about it. So what does this look like in the absence of EVD? So let's take Ebola virus disease out of it. When someone experiences sexual assault, what do we do? Well, there's a forensic nurse consultation. That includes the forensic nurse responding in person to that patient. We spend time building a rapport with them. We offer them a community advocate to sit at the bedside and help kind of make sure they're comfortable as we perform our medical exam. We discuss what their reporting options are, as well as what the mandatory reporting options are. We consent them for a medical forensic exam. And then what that medical forensic exam includes is going over post-exposure prophylactic treatment options. So that's treatment for gonorrhea, chlamydia, pregnancy prophylaxis, vaccinations such as hepatitis, tetanus, all of the HIV, all of those different things. Then we conduct what's called the medical forensic history, which is their medical history as well as the history of the assault. and we will use that history of assault to lead our head-to-toe exam looking for injuries that could have resulted of the type of the assault that they've experienced. So a head-to-toe exam, as well as those focus assessments based upon what's reported to have occurred during the sexual violence. And then that includes a speculum exam with a pelvic exam with a speculum insertion, looking for injury in the vaginal area or the vault, or for males, looking at the external genitalia for any trauma. We'll conduct forensic photography of injuries or findings if the patient consents to it. And then the sexual assault evidence collection kit is completed, which is 12 steps in that kit of swabs that we collect based upon the history of the assault that we learn. And then we go over discharge and follow-up plans. So follow-up for STI testing, follow-up for therapeutic and emotional needs, and follow-up for law enforcement regarding the status of their sexual assault kits if they did proceed with evidence collection. There are time frames with a lot of this. So typically most regions only collect sexual assault evidence collection kits up to 120 hours from the time of assault. HIV NPEP needs to be administered within 72 hours from the assault. And then pregnancy Plan B can only be administered up to 72 hours, while ELA is up to 120 hours. So there's a few different considerations that we have when we're doing these needs. So in the absence of an infectious disease, all of these things can be moving forward relatively smoothly. What all is included in that sexual assault evidence collection kit? Now, the patient picks and chooses what they want. We tell them what we think is beneficial to collect based upon what we have gathered during our history assessment and our forensic head to toe. But they can tell us what they want us to collect and what they don't want us to collect. But that kit includes a 13-page document of everything: medical history, forensic history, head-to-toe exam, photography log, swabs that were collected, chain of custody. All of that is in our documentation. And then the kit itself has all the envelopes plus possibly a disc of photographs that you're seeing on this slide. Now, when we're looking at a patient who may have Ebola virus disease and has experienced sexual violence, there's a lot of other considerations in this case. So one thing is medical care always comes before forensic care. If the patient is not stable, we do not proceed with forensic care. Their medical needs to be met, and that is the primary focus. Now, if they have medical needs, but they're also considered stable, if things can be done simultaneously, we do that all the time in the ER, so it could be done in this setting. It depends on the status of the patient and the comfort level of the primary care team who's overseeing that patient's care, and what they're okay with us doing and not okay with us doing. With this specific case, on arrival, the patient will be about 83 hours from the time of assault. So that's outside the window of HIV, outside the window for at least Plan B, but still possible for ELA if that's something that they want to proceed with. So we need to know, what capability is there for these options? Can these even be offered to the patient with where she's at right now? She is in transport. I doubt that they're going to have access on whatever type of transportation method of HIV, and she may be out the window for that, but that's a consideration that we want to think about. In the case of Ebola virus disease, I think it's probably safe to say evidentiary swabs are not going to be an option, because what happens with those swabs? They're swabbed on the patient, they have bodily fluids on it, they're taking out, and they're taken to a crime lab where it's processed. But when you have a special pathogen, that's likely not an option, and that's okay, because the evidence is only a part of that patient's legal outcome. All of the documentation and all the history that's done is still a big part, and that still can be done in these cases. We have to figure out who has jurisdiction over the assault, and is it a mandatory report? And with this specific case, there's a public health concern, possibly an infectious perpetrator. Like, how do you even begin to report that, and who do you even reach out to about that, and who has jurisdiction over that? So that's a consideration. The patient right. So we will follow the rights that the patient has in the area they're reporting to. So if this patient comes to Nebraska Biocontainment Unit and I'm asked to do a consultation with them, I'm going to provide them their rights because they're reporting in our state following our laws. Telehealth capabilities. What are the capabilities of this? Because we can offer a lot of our services without having to be in person, and we can still make sure that that person's needs are being met. What are the forensic examiner program capabilities? Do you have people who are even trained on proper PPE when it comes to certain disease? Or is that not a can of worms you're even going to open? Or maybe are you going to do just-in-time training to get them at the bedside? All of those things are things to think about. And then also the short and long-term health consequences of sexual violence. For this patient that's presenting, you have to recognize that crisis intervention will be needed because you can't discount that, yes, they have Ebola, and that's extremely scary, but you also have to think about all the psychological trauma that this person may have, not only from the sexual assault that they experience, but the significant the significant isolation they're about to experience, being quarantined on a biocontainment unit with a special pathogen surrounded by people who are in full PPE. What emotional toll is that gonna have on them, and how can you help intervene on that? I know we're short on time, so I'm going to go over these relatively quick, but there's a lot of short-term consequences when it comes to sexual violence. So that can be physical health as well as psychological. So on this slide is a list of variety of different things, which I think many people can probably anticipate. So there's a long-term injuries associated with what they've experienced, whether that be physical injuries, untreated sexually transmitted infections, a pregnancy as a result of that assault. But then the psychological, people can go into shock. They can have that emotional numbness. They disassociate. They don't remember everything, or they have PTSD where it comes back in flashes. And self-blame and guilt, feeling that that sexual assault was their own fault. Um, Kind of crossing over into those long-term considerations with that mental health is that PTSD, chronic pain from the physical injuries that they've experienced, and the social and interpersonal effects where they have difficulty trusting and difficulty building relationships with people. So those are all considerations. We also see a high risk of addiction and drug use, as well as self-harming or even suicidal ideation. And that's why we want to provide that crisis intervention immediately to get them on the road to healing as soon as possible. So what would this look like in the presence of Ebola virus disease? So what could we offer them? Well, we can still do a forensic nurse consult. We can still rapport build. We can still offer an advocate. Essentially, almost everything that you're seeing pop up in green on this slide, we can offer someone through telehealth services. The sexual assault evidence collection kit is probably something we're not going to collect. We could talk to the public health department about it, but there's really not it's not going to happen, and that's okay, because people always think that a sexual assault case and the justice for someone relies so heavily on the evidence kit, and while that is a piece of it, that is not the end all be all. So we can still do everything else, provide them their services, document what we're seeing through telehealth, because we do that currently for rural communities. We provide our services where someone in that space, such as a biocontainment nurse, is the hands and ears of us in the room, but we're doing all the documentation through telehealth, so we can still meet their needs. And then that discharge and follow-up planning. Those care delivery options can be trained personnel, where you have forensic nurses who are trained in PPE, do go in that room and do have those conversations at the bedside while in PPE and do document in the room. Or you can have someone who's trained to do all of that, be the eyes, ears, and hands in the room while the forensic nurse is outside the room providing those services via telehealth. Same with connecting law enforcement with telehealth to take a report, or connecting an advocate to provide education from the advocacy standpoint and make sure they know their rights and help plan for when they're discharged, all of those different considerations. When it comes to the forensic nurse, everything that you see in green can be done easily with the forensic nurse via telehealth. The two things here, so a head-to-toe exam, including the speculum exam and the forensic photography of injuries, may or may not take place with a forensic nurse in the room. You may have a forensic nurse you train on appropriate donning and doffing with just-in-time training, and you allow them to go in the room, or they have experience already with biocontainment care and they're a forensic nurse. They could potentially do those things in the room and documenting them in the room. Or, like I said, you have the biocontainment unit nurse or whoever that infectious disease nurse at the bedside be the role, be the hands, follow the instruction of their forensic nurse who's talking to them via that Zoom or that telehealth equipment that guides them through the exam while that forensic nurse is doing all the documentation. And then forensic photography of injuries, we recognize that maybe you can't bring in a camera and you can't bring it out and then store those photos, but can you use your telehealth equipment to zoom in and take photos? Or do you sacrifice the camera, bring it in, and you upload them to the patient's record directly in the room if there are injuries that are a result of that? So those are things you want to think about. This is just looking at, for example, the Nebraska Biocontainment Unit, how this could work, where you have a patient who's in a room and then a biocontainment or the forensic nurse in the room, while in the dirty space or the red zone, while in the green zone, you have the individuals, or even outside the green zone because it's telehealth, providing all of those other services that we talked about while they're safe, not at risk of contracting that infection. When we reflect on the conceptual model for this specific case, so what are the bidirectional risks associated? Well, we talked about the specific considerations for a patient who has Ebola virus disease, as well as the short and long-term health consequences, not only of Ebola, but of that gender-based violence. How can we act on them? How can the medical forensic exam be performed in the presence of EVD in a level that the primary healthcare team is comfortable with, the patient consents to, and the forensic team is able to meet that need? So just talking with all the stakeholders to figure out what do we feel comfortable and what can we do to meet the guidelines while also making sure we're addressing the gender-based violence that this person's experienced. And then who should be involved? This is really where it comes time to, a lot of the time we focus so much on after action reports. You need to think about that before action review. Think like this is going to happen. I have a picture of Edward A. Murphy Jr. on the slide because Murphy's Law, anything that can happen will happen. It's going to be a perfect storm. So this case study may seem extreme, but what we do know is humanitarian workers respond to areas of infectious disease and violence. We have research that shows that humanitarian workers also can sometimes be can victimize other individuals. So it's not outside the realm of possibility. So how would you meet these needs for someone who's experiencing this psychological trauma following violence? And forensic nurses are a prime location to be part of that team to think about, here's what we can do, here's what we can't do, and why, and then develop that policy ahead of time so you're prepared. So kind of in conclusion, always remembering that the patient's health and well-being is always the first priority. And the effects of violence can be very, very subtle. The injuries that we see with sexual violence are not typically extreme lacerations, bruising, or high-risk situations or trauma. They're usually pretty subtle, but those subtle injuries are important when it comes to justice in court proceedings. Evidence collection is important, but it's not an end-all be-all. So if you can't collect the evidence kit on someone, that doesn't mean you don't consult a forensic nurse. There's still so much that patient can be offered in terms of gender-based violence that could both promote their health and promote their legal outcomes. And then lastly, I feel I've said this already, but every survivor deserves access to specialized care. Don't get so distracted by the disease or the other trauma that they may experience. Look at them holistically, because the short and long-term consequences of sexual violence can be extreme. That is my references, and I guess I'll take any questions anyone has.
Just want to remind folks, first of all, I understand we're getting right here at the top of the hour, so I want to first and foremost thank everybody for joining today, and I want to thank Kaylin for talking all about this. That was a lot of information for sure. And if you have questions, by all means, put them in the Q&A. I guess two questions. I mean, one of them you kind of touched on a little bit about using telehealth with it, and I guess I just wonder um, the not necessarily the telehealth capabilities, but more like telehealth allowances, what's covered, what's not covered, in terms of what's allowed. It's a shifting landscape, right? Is it just mental health? Is it something else? Any number of things, right? It's kind of a moving target as to what you can use it for. Is like, how is that affecting the ability with forensic nursing doing that too? Because I especially see with rural areas, telehealth's going to be probably their main way to be able to do any of this stuff.
Yeah.
So
Yeah, so our program at Nebraska Medicine, we have two telesane contracts with two rural community hospitals in Nebraska that we provide our forensic nursing services to. And the biggest challenge with that is when you get up and going is not only the contractual relationship that goes along with that, but the securing those connections with those people when you're talking about violence and you're viewing intimate areas of a patient on a Zoom, making sure that you have a secure connection with those individuals and making sure that the people that you're talking to at least have a baseline understanding of what they're going to be asked to do as the hands, eyes, and ears in that room when you have a forensic nurse on the telehealth hub. So we always do what we refer to as that just-in-time training with people, where we talk them through, here's the forensic exam, here's what we do as forensic nurses when we're in person. Now that we're not in person, here's what I'm going to do, and here's what I'm going to
Mhm.
ask you to do. And we walk them through all of those portions to make sure we can answer their questions. And the biggest thing that we have found to date, the biggest challenge we face with telehealth is we can zoom in. We have pretty good cameras to zoom in and view injuries, but we are through telehealth, but we are also heavily relying on the assessment skills of the provider or clinician at the bedside in that room because their assessment is becoming part of our documentation. And we're putting a note in our documentation that this services was provided via telehealth with limited capacity during these portions of the exam. And we have to be comfortable speaking to that in legal proceedings later on. So that's just kind of one thing when it comes with telehealth, but we have found that telehealth really is becoming the way forward for forensic nurses in those rural communities because there's just not funding to support formal programs in regions that have a lower volume.
Mhm. Okay. I'm going to go to this other question that came here. It asks, for children who stay home ill from school, is there research on negative outcomes, thinking more about children who can't go to school due to isolation, but then the home is not safe either?
So specific to, there is a lot of research that speaks to the broad amount of violence that escalated in homes that have intimate partner violence and domestic violence occurring. And what we do know from the research of violence is that when children are in the presence of violence, it increases their chances of becoming victim of violence as they get older in age, but also at risk of becoming a perpetrator of violence. So there is negative consequences relative to children being in isolations of homes that do have that violence. Now, I've had cases where perpetrators abuse the other parents in front of the children on the daily. I've had cases where they abuse the children and the other perpetrator. And I have cases where the only people that know that the violence is happening is the perpetrator and the victim, and the kids aren't even aware that that violence is happening. But it does put them at increased risk when they're in that household, and there's a decreased risk of there's an increased risk of lack of resources. Like in the COVID-19 pandemic, we found we had no shelters we could send people to that had kids. So if we had a mother who wanted to leave an abusive relationship with a child, there was already limited beds because of social distancing, but there was an increased number of places that no longer took in families. So that was another challenge that was significantly hard to overcome, where we had to work really closely with our local advocates to figure out what our options were. And we relied heavily on funding to support putting them in hotels with their families.
Okay. Well, I don't see any other questions there, and I see we're at four after, so I'm going to respect folks' time and everything. Again, I want to thank everybody for coming to this presentation. Appreciate you coming on, and I appreciate everybody being here today.
Thanks, everyone.